children. So the poisoning in children is something which is little different as compared to when you look at the spectrum of poisons which is consumed or which causes toxicity in children is slightly different from the adult population, because in adults generally it is intentional, either it is by self or by some poisoning by intention by other people. But in children, it is most of the time accidental poisoning or accidental toxin ingestion by children without knowing that something is going to be harmful. But children are, like at young age, they are very curious about different things and they have a habit to put everything in their mouth. So they reach out to different things and keep putting them in mouth. So that can lead to the basic difference. So this statement that all things are poisonous and nothing is without poison, only the dose permits something not to be poisonous. That means that what it reflects to the actual scenario in pediatric poisoning or toxin ingestion cases. So most of the time they will actually consume something which is a day-to-day product which will be used for some other purpose. Sometimes they swallow kerosene oil, or sometimes they actually take medicines of elderly people at home, or their own medicines they can just consume because of the taste they will take in high amount. These kind of things happening in children. Sometimes button batteries they will swallow. So out of curiosity, children keep taking different kind of food, different kind of toxins, which is actually harmful for them without knowing that it is harmful. Whereas in adult, it's intentional by the person or somebody else wants to create that situation by poisoning somebody. So that is the common scenario in adults. So that is the thing which is the difference between the epidemiology of poisoning in children compared to the adults. So mostly the poisoning in children happens to the common through the common household poisons. Like I already spoke, different kind of medicines used by the adults, kerosene, turpentine oil, or different kind of mosquito repellents. These things are quite often swallowed by children, and sometimes different kind of cleaners, bathroom cleaners, Harpic, all those things also have been seen to be swallowed by children, and these things can lead to poisoning. So now looking at we will just go through a case and then try to understand as to how to approach a case of toxin ingestion or poisoning in children. So here is a case of 2-year-old child who was brought to ER and was unresponsive. And the parents suspected that the child has ate or consumed something which is non-edible substance and which may be poisonous for the child. So they come in the situation because child was previously well, and after a brief period of not observing the child, suddenly they found the child to be unresponsive. So on the arrival in the ER, the child had a GCS of 10/50. According to the ABPU corresponding scale, child was responding to pain only. Child was, although hemodynamically stable, heart rate and rhythm was normal, but the breathing was shallow with the room saturation on room air was 92%, and the chest was clear. So this kind of a child generally indicates that the child may be having swallowed something which is kind of a CNS depressant, because the sensorium has altered and the breathing is shallow. These kind of patients, we now think of what we can do in an approach to management of a toxin ingestion or poisoning in a child. So coming to the approach, when we don't know what kind of poison child has swallowed, so we have to go through an empirical approach of different kind of elimination techniques which we can employ to remove the toxin from the child's body, and then see what we can do best in terms of antidotes, because antidotes can be only rationally employed when you know what is the toxin which has been consumed by the child. So first step is in analyzing a child with poisoning is taking a brief history, because unless you know a little bit history, you won't be able to predict what kind of poison the child has or toxin the child has consumed. Then doing a clinical examination, just like any case of emergency, you do a vitals examination, look at the important systems and try to find and figure out what is exactly happening in terms of different disturbances or what are the derangements happening in the clinical examination, and then finally switch on to the some basic investigations followed by specific investigation to find out what kind of toxin the child might have consumed and what kind of metabolic derangement has happened because of that. The first thing is always remember in emergency, no matter what kind of emergency, the resuscitation is the most important thing. And what we say is the ABCDE support is the basic care. Then thinking of the reduction of toxin absorption and helping toxic elimination by different techniques, which I will come to in few minutes, and use of some specific antidotes in particular situation. Then finally, one more important thing, which as a new doctors, you should all know that medical legal documentation is vital, is very vital for nowadays, because more and more situations are arising where doctors are at fault of not documenting what interventions they have done, and later they have to suffer because of that. So it's very important to do a police case registration, even if it is accidental poisoning in children. And that is my experience in Aster, leading the emergency team for a very long time. This has been a very initially it was a confusing thing, but later on we refined our protocols to such a level that every case of accidental ingestion, no matter what it was reported to the police and it was documented properly. And thereby we were safe on our side that at least we have informed the concerned authority. And then finally, counseling the parents, as well as if the child is appropriate age for counseling, then we can counsel the child also about the incidents which has happened and how to prevent these things in future. So this child safety protocol also is important. So in individual steps, the most important way of like limiting the damage which is caused by the toxin is definitely decontamination. I think somebody's mic is on. Can you mute yourself?
Yeah, I've done it.
So decontamination is can be done at different levels. Dermal decontamination, ocular decontamination, gut decontamination. So dermal decontamination is very common poison, like organophosphorus poison. Organophosphorus poison is a poison in which, like I have seen a lot of cases when I was a student in a rural area I used to work, and then organophosphorus poisoning was very common in the agricultural workers because they used to consume that, or sometimes children also unknowingly, because in agricultural society these kind of things will be used as pesticide. They will keep it in a place where children sometimes will swallow it. What happens is it has a transdermal absorption property, organophosphorus. So as soon as the patient arrives, you have to remove the clothes, wash the skin of the child or the patient, so much so that there is no leftover part of the poison on the skin, so that it will not get absorbed. Similarly, ocular decontamination is in any corrosive agent which has been exposed to the eyes. Gut decontamination, will come to that in a very detailed way, and we will discuss this. So gastrointestinal decontamination, there's different kind of options available. So initially in the previous times, people used to induce vomiting in order to remove the poison, and in rural societies and even unaware people, common people try to induce vomiting whenever they think the child has swallowed something. They try to induce vomiting and take out the poison by vomiting. But as the science has progressed, it has been found that trying to make artificial vomiting for removing a poison is not a great idea. And we have moved on to more sophisticated and more effective ways of removing the poison from the stomach and the GI system. So among that, we have the options of gastric lavas, using of activated charcoal, which is the adsorbent material, and doing whole ball irrigation. These are the options which generally help GI decontamination. So now, when you look at a wholesome approach to a poisoning or a toxin ingestion, first is you have to treat the child in definitely an area where you have specialized care and good monitoring. That can be a pediatric emergency or a pediatric ICU. And therapy should go hand in hand. Like always we discussed, when we manage a child, there has to be a continuous assessment, and parallelly you have to continue the initial stabilization. That stabilization is very important to save the life. You cannot wait. So definitely teamwork is required for that. Multiple doctors and nurses will take care of different part of the care. And the approach generally, like we know, ABC means appearance, breathing, circulation. That is the initial impression. That is the doorway assessment, and then followed by primary assessment. That is the airway, breathing, circulation, disability, and exposure. So these things are the like basic construct of any pediatric emergency, and it also applies to any toxicology case or poisoning case. So one more thing which is very important is many times people misdiagnose and don't understand a case because they don't have the suspicion. Initially, young people who are just beginning their training in the subject of pediatrics, they might get confused of different syndromes which will be there because of the poisoning with diseases. So many times it has been seen that patients have come with respiratory distress, and they actually are found to have actually organophosphorus poisoning or a kerosene oil ingestion in some duration back. That history and that thought process of actually excluding the poisoning is very important. even the cases of severe metabolic acidosis, which is unexplained, these can be some poisoning. So we have to always think of poisoning when the particular case does not fit into the particular history or the examination pattern. So poisoning is always a possibility. So then again, if you're thinking of poisoning, you have to keep some samples to do some toxicological analysis and look for the common poisons which can be tested for. And having said that, I admit that most of the poisons cannot be tested for, and the tests are not easily available at every place. Higher centers sometimes do this, but it's very difficult for us to always pinpoint what kind of poison child is consumed, because there's a large number of things which can cause poisoning, and not every test can be employed everywhere. So that is one important thing. Then coming to poisoning center, information center. This has been my personal experience when I was in Delhi working in Sir Ganga Ram Hospital. We always used to call AIMS New Delhi Center, Toxicology Center, that is the National Toxicology Center, and they generally guide on a 24/7 basis as to what to do for a particular type of poisoning. And that's a very efficient system over there, and there's a common number which is available. You can call and always ask about your doubts about a particular poison when you don't know what is the exact treatment or whether any antidote is available. They generally guide us in that way. And for abroad countries also, they have a central toxicology center where they will actually analyze the toxins and even guide about the antidote therapy. Then decontamination, as we discussed, and we will be further discussing the details of decontamination and GI decontamination again as two parts, decreasing the absorption and allowing more elimination. And then further elimination by other techniques like urinary alkylation, hemodialysis, and hemoperfusion. Then finally, if it applies to a particular poison or toxin that a specific antidote is available, then definitely it is the best way to treat and preventive strategies for future. This is the general construct approach of poisoning case, and I'll be going into details slowly of a few cases. So this is just the revision of the thing I discussed just now, that there is always an initial impression, that is the awareness, that is the A it's called consciousness here, but A for awareness, then B for breathing, and C for color. ABC, initial impression. Initial impression, just coming back to the emergency thing, initial impression is the impression which you make without touching the patient. Looking from a distance, you get an idea whether the child is sick or not. Then primary assessment, definitely you will examine each system in a way to find out life-threatening emergency and try to address those emergency. Then find what are the problems and treat each of the problems before moving on to the next system. So if airway is blocked or airway is compromised, then better treat the airway, maybe intubate or put a oropharyngeal airway or somehow clear the airway, and then move on to the breathing part and assess the breathing part and provide oxygen and all those things. Then circulation like hemodynamic stability, and then looking for the neurological compromise. So like that, in sequence, we have to evaluate, identify the problem and do interventions at each level before moving into the next level. Secondary assessment, we all know in the PALS algorithm comes as sample, and we all are aware of signs, symptoms, allergies, medical history, past medical history, and which medication patient is taking, last events leading to hospitalization, and further physical examination and some bedside tests. Now for basic tests for any patients who come for poisoning is basically doing a ECG, putting the child on a cardiac monitor, monitoring the heart rate, BP, all these vital parameters along with saturation and respiratory rate. Doing a chest X-ray and abdomen X-ray sometimes may give you some clues, and ABG and analysis of anion gap and osmolar gap sometimes give you another separate idea into categorizing the poisoning. And sometimes diagnosing the poisoning, because see, it is not always very straightforward to diagnose toxin ingestion or poisoning in children, because most of the time parents would not, as to what the child has consumed, what has happened, what has gone wrong. Few times you may see that bottle is empty or the tablets wrappers are there. Sometimes it will be that totally there will be no clue for the parents to know what has exactly led to this situation in their child. So, and then specific suspect like particular drug has ingested. Suppose let's say if somebody's family, somebody was valproate anti-epileptic drug and child has consumed that, then you can do a specific drug levels to know that okay, what is the valproate level in the child's blood. So these are the scenarios, and these are the kind of tests which you can do empirically when a child with poisoning, and then later be guided according to the problem which is the child presented with. So what sample to be sent, where to send, and any government authorized body. This is again, it depends on the institutional protocol as well as the centers. So sometimes you have to take take help of the toxicologist. What we do is whenever we do NG wash, we try to keep that NG wash sample for both medical legal purpose as well as for toxicological analysis, as well the urine sample and few blood samples, EDTA, serum samples, and heparin samples for future analysis. So you keep those samples in case you need it in future for toxicological screening, and send it to a center which may have a further higher center for toxicological analysis. If your center is not providing those facilities, and always coordinate with the local government authorized centers that will be keeping you safe in future in case it turns out to be a medical legal case. Now coming to common toxidromes, so toxin ingestions have been clubbed together based on their classical features, and they have been named like that. So we will be briefly going through what all these toxins and what all features they generally present with. So first of all, the most common or most well-known toxidrome is the anticholinergic drugs like atropine, glycopyrrolate, or trioxyphenydyl. These drugs, and some antihistaminics like chlorpheniramine, which is very commonly used in cough syrups, cyproheptadine, and these hydroxygen. These are all very common and medicines which are used on day-to-day basis in OPD practice. And sometimes children happen to consume these medicines because the elderly people will be keeping it in a place where they can access it. And young toddlers, they don't know what is to be consumed and not consumed. They are very curious about their surroundings and they end up consuming these things. So in anticholinergic poisoning, the classical features which you'll see is there's increase in heart rate and BP. The respiration generally remains unaffected. The breathing system is okay. The temperature will go high. The child will be vasodilated. Pupils will be dilated. Bowel sounds will be absent, and there'll be a lot of diaphoresis. Means a lot of secretion will they will be dry. They will not have any secretions. So generally, these are atropine kind of classical atropinization. I think some of you would have seen in your undergraduate life how we used to atropinize the children, the patients who had organophosphorus poisoning. So they will be dry, their skin will be dry, their secretions will be dry, their pupils will be dilated, and heart rate will be high. This is classical atropinization, which I recall from my training in earlier times. This is one very classic anticholinergic syndrome. So cholinergic is just kind of opposite of anticholinergic. These are the drugs like organophosphorus, which I already discussed sometime back. I mentioned about it. Organophosphorus is a common poison which is used in rural India and for as a pesticide. And many times it happens so that the parents are kept in such a place that child consumes it. It can also, similar syndromes can also happen by taking pilocarpine-like drugs, carbamates. Carbamates again are used as a this thing only, pesticides. Sometimes some kind of mushrooms also leads to cholinergic syndrome. So cholinergic syndrome, the classical thing is you would have pinpoint pupils and lot of secretion. So there will be excessive salivation, excessive drooling, excessive bronchoria, means there will be wheezing with lot of secretions in the lungs. And the child will have tearing and all this urination, excessive bowel motions. So all these things are very characteristic of a cholinergic poisoning. And these kind of patients sometimes get mistaken by young people as young doctors as something with respiratory distress pulmonary edema, because there's a lot of pulmonary secretions come, a lot of wheezing happens at the time of cholinergic poisoning. So that is one thing. Then coming to opioid poisoning, as we know previously, codeine was used as a cough syrup, but now it has been banned. But different kind of medicines still are having some amount of opioids, and people sometimes use it in different ways. And this opioid poisoning classically presents with a bradycardia, pinpoint pupils, absent bowel sounds, and more of a dry skin and everything with hypothermia. Generally, these people will be hypothermic and they will have respiratory depression also. These are the patients whom you think need to be treated like opioid poisoning. Then sympathomimetic patients are the patients who are more or less kind of a similar to the anticholinergic patients. So they will have high heart rate and BP. Their respiratory rate will be a little high. The temperature will be high. But the only difference between these two is the sympathomimetic patients will not have dryness. They will have more of secretions. So they will be having a lot of lacrimation, salivation, all these kind of things. And their bowel sounds will be more. Then finally, sedative and hypnotics. The case which we discussed in the very beginning, the case one we are discussing, can be a benzodiazepine poisoning. What happens in benzodiazepine poisoning? many people, because adults will be taking anxiolytic medicines, they will be having alprazolam or some amount of different kind of benzodiazepines for their anxiolysis and depression, and different kind of medication people are using. These sedative hypnotics can be consumed by children and can lead to features like low heart rate and slow breathing, hypothermia. Pupils generally are not very badly affected unless there's severe overdose. Then bowel sounds will be less and the child will be dry. These kind of things, excessive sleepiness and unconsciousness is this one feature which will be prompting towards thinking about sedative hypnotic poisoning. So now this is the picture which is classically described. I think we have all gone through this one part once in a while. That is the endogeneous toxidrome, that is hot as a desert means child is hyperthermic, blind as a bat means because pupils are extremely dilated, they cannot see properly, their vision will become blurry. Mad as a hatter means the child will have tremors. Dry as a bone means the urinary tension, the dry mouth, these are the classical things. And red as a beet means the skin will be flushed. These things are basically to describe the classical anticholinergic toxidrome, which is, in other words, we used to call as atropinization. So extreme atropination leads to syndromes like this. Coming to just general clues into what all poisons can lead to what kind of syndromes and symptoms. So like the ataxia can be caused by carbamazepine poisoning. I have seen these cases. So like these phenytoin toxicity, thallium, ethanol, these are all situations where you will have ataxia. Coma, like I discussed just now, opioids or hypnotic sedative agents, alcohols, tranquilizers, these are the things which can lead to coma and unresponsiveness. Convulsions happens in TCD, tricyclic antidepressant ingestion, and different kind of amitriptyline ingestion and all those things. Respiratory tract depression is again ingestion, opioids ingestion, and alcohol intake. Pulmonary edema is common with acetyl salicylic acid, that is aspirin poisoning, and different kind of organic solvents and paraquat. So paraquat is one of the most dangerous poisons. And unfortunately, recently I saw 2 cases of paraquat poisoning. And it was a very strange case where the paraquat was bought online by a student girl who was 17-year-old. She consumed it and it is almost nearly fatal, always fatal. Paraquat poisoning is a very slow evolving poisoning, but it's very difficult to treat paraquat poisoning. And very unfortunate to say that paraquat poisoning are most of the times very fatal. Hyperapnea means tachypnea basically, that happens in aspirin poisoning, ethylene glycol poisoning, or different kind of methanol and isogen poisoning. So these are the common features associated with different kind of poisonings. Okay. Coming to circulatory features, tachycardia is generally, I discussed just now, anticholinergic and sympathomimetics will have tachycardia, whereas bradycardia in cholinergics, beta blockers, digoxin, opioid ingestion. Hypertension common in anticholinergics and sympathomimetics, again hypertension with ethanol and sedative hypnotics poisoning. Arrhythmias is common in beta blocker, cyanide. Digoxin is an agent which is commonly used for arrhythmias, but it is one of the most arrhythmogenic drug itself. So it has a classical arrhythmia by itself named by digoxin like arrhythmia. So these things are very, very common with some of the drugs which are actually used for antiarrhythmic. Amiodarone is one more drug which is used as antiarrhythmic, but it has in itself multiple arrhythmia induced by amiodarone or electrical abnormalities. Then coming to eyes, when you look at eyes, you will see meiosis. Meiosis, like I discussed some time back, the pesticides, the one with organophosphorus or carbamates, they are classically presenting with meiosis. Opioids also present with meiosis. These are the drugs, and some drugs like phenothiazines. Then mydriasis is commonly seen with atropine, we have discussed, and TCD, cyclic antidepressants. And nystagmus is commonly seen with phenytoin toxicity, very common. Phenytoin toxicity generally we have seen in patients who have been given wrong doses by parents. Many times it happens that parents don't realize they're giving a wrong dose because the preparation or the tablet dose which was written, they're using the number of tablets, but maybe they're using 100 mg tablet instead of 50 mg tablet. And this confusion sometimes lead to anti-epileptic drugs poisoning. So nystagmus is very classical in a phenytoin toxicity. So I have seen these cases. Then body temperature, hypothermia with aspirin ingestion and different kind of phenol ingestion and quinidine, procanamide ingestion. Hypothermia is a classical feature in opioid poisoning, ethanol poisoning, or hypnotic sedative agents poisoning. Then skin and hair loss. This is organochlorine poisoning have like hair loss and skin problems in the long run. GI symptoms, hypersalivation, I discussed already, cholinesterase inhibitors, trypsin, this all things hypersalivation, and this ones, your organophosphorus poisoning also has massive hypersalivation. Dry mouth is classical in atropine poisoning, opioids ingestion, and tricyclic antidepressant ingestion. Constipation in again opioid poisoning, lead poisoning, these are the common features. And diarrhea in cholinesterase inhibitors and laxative ingestion. So laxative ingestion can lead to a lot of diarrhea. So you have to think like this and find out what all the common poisons can lead to what kind of features. This general knowledge sometimes helps us figure out what is the poison we are suspecting. Now coming to an interesting concept, what is the osmolar gap concept? We know how to calculate osmolarity of the blood. So we know that 2 into sodium and glucose divided by 18 and 1 divided by 2.8 gives us the osmolarity of the blood, and the general osmolar gap. Osmolar gap is the measured osmolarity of the blood and compared to the calculated osmolarity. Generally, the gap is between 10 to 15, but there are certain poisons which actually lead to a higher osmolarity without being measured into the common osmolarity. This thing. So with the calculation, they will not come and they will act as poisons will act as a osmolar agents. So generally we know them by the mud piles acronym. There's methanol, uremia, decay in ketosis formation, aldehyde poisoning, iron poisoning, lactic acid because of any reason, ethynyl glycol poisoning, and salicylate poisoning. So these are the things where the this osmolar gap will increase. So now coming to gastric decontamination, already I had brought this up in some time back that this use of anti-emetics to remove the poison from the stomach is very like logical. People think that child has or patient has swallowed something, so we use emetics to remove those things and it will come out. But it is not advised because most of the times what happens is when you trigger vomiting, you increase the risk of aspiration, and sometimes because of these things, the poison may actually pass on to the distal stomach, distal intestine. And that's why now currently we don't use any kind of emetics to treat the patients with poisoning. Ipecac was one of the common emetics which was used in past time, but generally nowadays it has been actually not recommended. What is the role of gastric lavage? Now coming to gastric lavage, in initial part of our training, we were taught that any poison patient comes, you do gastric lavage and remove the poisoning. That is again logical, but gastric lavage, there is some time duration that in this particular time frame it is effective, and there are some toxins for which we should not do gastric lavage, and there are general rules as to how to do gastric lavage. So we'll look at it. So the gastric lavage, the idea is it removes less than half of the most of the substance if it is performed promptly, and then definitely it should be done within 2 hours of ingestion. After that, it is very like not that much useful, but generally we tend to do it up to 4 hours. And if the drug which is used and generally impairs gastric emptying, then we can do it even later. So gastric lavage is the norm unless it is the contraindicated. So when the child is totally having altered sensorium and poor pharyngeal reflex, it makes sense to actually intubate the child. That means basically when the airway is not maintained, you better intubate the child before putting a gastric lavage, because while gastric lavage, there will be always a high chance that child may have aspiration. Although intubation does not 100% guarantee that aspiration will not be there, but with a cough tube, definitely you can minimize the aspiration. So how much saline to be used for gastric lavage? Answer or reply in the comment section. Anyone? Can anyone tell me how much amount of NS should be used for gastric lavage? I'm waiting for a response.
Somebody, yeah.
10 ml per kg. Dr. Mowgli Raja, 10 ml per kg. S. Kumar, 20 ml per kg. Okay, come on. Anyone else? Okay, thank you for the responses. I'll move on. So actually it is said that we should use 15 ml per kg. And in adolescents, 200 ml. So 15 ml per kg is the standard amount we should use. But the general, this is just a general guidance for you. But remember that you should do gastric lavage till the time your effluent matter is now clear. It is coming clear like water. So that is what it is there. Okay. So generally for gastric lavage, try to use the largest size orogastric tube possible, and at least 10 French should be used. Okay, less than 10 French will not be effective in removing the poison because the lumen will be too small. Try to use maximum size which is possible. Now, what about activated charcoal? How does activated charcoal work? Activated charcoal material, what it does is it actually retains the poison or the toxin on its surface, and what it will do is it will allow the like charcoal will bind to the toxin and it will come out in the stool. So the toxin will or the poison will not get absorbed. So in the stomach where the toxin is there, the charcoal will go and bind and will neutralize the toxin. So that the toxin cannot be absorbed in the intestine. That is the main idea of giving activated charcoal. I think all of you would have used activated charcoal. It is very common to use these things. Okay, and it is helpful also. Okay, so one interesting question: what happens if activated charcoal is aspirated? What do you think will happen? I'm looking for responses. Activated charcoal ingestion, when you are doing, suppose putting the activated charcoal in the stomach for adsorption, if somebody aspirates activated. Okay, so I think all of you must be aware, it is very common that activated charcoal, if it is aspirated in a small amount, because it's a very highly active substance, it can cause severe lung damage and it can cause pneumonitis of highest degree with ARDS. So be aware that when you're putting charcoal, be careful that you should not induce aspiration. Okay. Dose, I think all of you know that 1 gram per kg is the dose, and multiple doses can be given provided that activated charcoal is indicated. Okay. So then what is the situations where you should not use activated charcoal? Remember these things which are not actually helped by activated charcoal. There's common electrolytes, iron, mineral acids, alcohol, cyanide, most solvents and pesticides, and lithium. So these are the places where activated charcoal will not be helpful. Avoid activated charcoal if endoscopy is anticipated, because if the charcoal is put in the stomach or intestine, you will not be able to see the mucosa. What are the other specific adsorbents used in special situations? Fuller's earth for paraquat poisoning, potassium ferrocyanide for thallium, milk for fluoride poisoning, sodium polystyrene sulfate for lithium, and cholestyramine for linden poisoning. Okay, now, what is the role of whole bowel irrigation? So certain situations actually where patient is actually has come late and the poison has already passed on to the intestine and the poisons is not actually adsorbed by charcoal. So these kind of places you actually may have to go ahead and use whole bowel irrigation with balanced solutions like polyethylene glycol and different situations. So this is one situation. Then what are the excretion techniques? Use of alkalinization. So you use sodium bicarbonate infusion to remove from the blood those poisons which are slightly acidic, like salicylate. Salicylate basically means aspirin, phenobarbital, and tricyclic antidepressant. These are the drugs which actually help by the urine. So you give bicarb with the target to achieve urine pH of 7.58 around. So that means once it becomes alkalized, urine becomes alkalized, means these small weak acids will bind to that alkali and get eliminated through the urine in the body, from the body. So multiple doses of charcoal can be used for some specific agents where actually it is very helpful, like phenobarbital and theophylline. Hemodialysis, I will come to it, how to use hemolysis for removal of toxins from the body. Generally useful in severe alcohol toxicity, aspirin toxicity, and lithium toxicity. So now coming to dialysis, which are poisoning and what are the criteria for using hemodialysis? So basically those poisons which are water soluble and have a low volume of distribution. So the idea is with hemodilution, you are removing it from the blood. So if a toxin is not staying in the blood compartment and it is largely distributed in the extravascular compartment, then hemodialysis will not be effective. So it is used for those poisons which are actually remain more into the blood compartment and have a lower molecular weight, because if the molecular weight is large, then they cannot be filtered out from the hemodialysis filter. As we know, every filter has some porosity, and the pore size determines what kind of molecular weight molecules can be filtered out. Then again, if some some poison is highly plasma protein bound, then they cannot be excreted by the hemofilter, because plasma proteins generally don't get filtered through the hemofilter or hemodialysis. So this is the thing. And the poisons which are commonly used, for which we can use commonly hemodialysis, is lithium, salicylate, methanol, ethanol, aminoglycoside, bromates, ethanol, isopropyl alcohol, metformin, thallium, and prokinamide. These are the common poisons where we can use hemodialysis. Hemoperfusion is basically when you are trying to remove by adsorbent technique. Toxin must have high affinity for the adsorbent and fast rate of equilibrium from the peripheral tissue to the blood. Means basically you put some this thing toxic this adsorbent material in the peritoneal cavity and then take it out. So not limited by plasma protein binding. Theophylline, atenolol, carbamazepine, diisopyramide, paraquat, all these are somewhere we use hemoperfusion. Hemofiltration, again, for larger molecules, you use large size filter and try to filter it out, like heparin, insulin, vancomycin, and myoglobin. Now coming to a common question. So which is the antidote for acetaminophen? What is the antidote for acetaminophen poisoning? I'm looking for some responses. Paracetamol poisoning, what is the antidote? Is activated charcoal useful in anesthesia in paracetamol poisoning? Actually, activated charcoal is indicated if the child is presenting within 1 hour to you in paracetamol poisoning. It also binds and it is helpful. So you can use it. Okay, we have used it. Now coming to the common like antidotes, we know all of them mostly. For paracetamol, you already told and anticholinergic. Like for anticholinergic, we use physostigmine. Then calcium channel blocker, calcium gluconate. Cholinergic poisoning, you have to use atropine. So cholinergic is basically, like I said, organophosphorus and carbamates. Okay, these are the things. And clonidine is poisoning is there, means you use naloxone. Cyanide poisoning, then ethylene glycol, you have to use dizibind for digoxin, ethylene glycol, fomepizole, and hypoglycemia, definitely dextrose, and iron desferrioxamine. Then isoniazide, we basically use pyridoxine. Methanol poisoning, again fomepizole. This means for all the alcoholic agents, this is alcohol dehydrogenase inhibitor. So that is the thing. Methemoglobin, you have to use globinemia, you have to use methylene blue. And can anyone tell what of the agents we use in our day-to-day practice can cause methemoglobinemia? Any of the medicines which we use or any agent which causes methemoglobinemia? Anything we use can cause methemoglobinemia? Any of the drugs or any of the medicines? Yes, yes. Sodium nitrophosphoxide, dapsone, sulfur drugs, and inhaled nitrophosphoxide. So when we do this for ventilated patients, that also can cause methemoglobinemia. So the treatment is use of methylene blue. Opioid, we know naloxone. I think at one point in your career, maybe once you'll get opioid poisoning and you'll see that naloxone being used. And oral hypoglycemic octreotide, organophosphate. Pyridoxine is the agent of choice for organophosphate, but definitely it is it is within a window period, 12 to 24 hours you can use. Beyond that, atropine helps. Atropine is so the specific antidote is definitely pyridoxine. Then phenothiazines, benzotropine you have to use. and sodium channel blocker, sodium bicarbonate, tricyclic antidepressant. I told it's a mild acid. So if you alkalinize the urine, then excretion through the urine will be better. Rat poisoning, if it is warfarin based, like coumarin derivatives poison, then vitamin K is helpful. Okay. So then, so what the learning is, what are the most common? So basically, any toxic agent which adults are consuming as their medicine can be a poison for a child. And there are many of like that. So in the first case, which we discussed, the child presented with altered sensorium and shallow breathing with normal hemodynamics status could have been a benzodiazepine or any kind of a sedative hypnotic drug, which has been used by the adults in the family and child would have accidentally consumed it. So now coming to case 2. Basically, case 2 is a child who is a 10-month-old infant, accidental ingestion of 20 ml of sewing machine lubricant. Sewing machine lubricant, I don't know. Nowadays, people are not using sewing machine that much, but in our time when we were kids, every household used to have a sewing machine, and we used to use the torn clothes again and again after sewing it. People have become more fashionable and not using those things. But though in rural areas, still you will find sewing machine, and it has a lubricant. It's a organic oil basically. And when the child consumed that and the child had cough and one episode of vomiting after ingestion, there is no fever. But now child is presented with tachypnea and dry cough, and the respiratory distress is progressively increasing with time. So what is the main problem with this kind of situation? What will happen? What do you anticipate is the main problem here? Means in terms of pathology, what is the problem which has happened? I'm waiting for some responses. Correct. So aspiration pneumonitis is the common problem which happens when you ingest this poison. So one more question is what you should do if you are having this patient, whether you should do a NG wash or not. Do we need to do NG wash? Correct. So patient is irritable, tachypnic, tachycardia is there, BP is okay for 10-month-old, 80/48, we can live with that. Perfusion is normal, saturation is 83% on room air and 96% on NRM mask. NRM mask is the mask which provides above 95% FiO. Nasal flaring and other signs of respiratory distress like subcostal, suprasternal retractions, diffuse crackles, cardiac and abdomen and neuroexamination is normal in his. So you will do stomach wash or not? You said no. Definitely stomach wash should not be done in this kind of hydrocarbon poisoning or any kind of oil poisoning like kerosene oil and all, turpentine oil, turpentine oil, this kind of sewing machine oil. These are all hydrocarbons basically. In these hydrocarbon poisoning, NG wash is not indicated. So no, neither NG wash nor charcoal not whole bowel irrigation is useful here. So what are the poisons or situations where gastrolize is contraindicated? Now coming to this point, can I have some responses? Where and all we will not use gastric lavage apart from the hydrocarbon poisoning. Just we had discussed this some time back. Corrosives, acids, oils, kerosene, very nice. Few more. I'm looking for few more answers. Rat poisoning, okay. What else? Few more common poisons. Come on. Okay. So there are iron poisoning, lithium poisoning. These are all, and there's an acronym for that. Camphor, halogenated hydrocarbons, aromatic hydrocarbons, metal poisonings, pesticides containing hydrocarbons. So these are the place where you should not use. The acronym is CHAMP. So in these situations, you should not use gastric lavage. So how you'll manage this case of hydrocarbon poisoning? What is the important treatment here? What is the treatment for hydrocarbon poisoning then? Aspiration pneumonitis happens. Yes, correct. Symptomatic treatment, supportive care. Basically, if there's respiratory distress, then you have to give some supportive care, either HFNC, non-invasive ventilation or ventilation, any kind of oxygen therapy. These are the things which we'll be doing and waiting for the pneumonitis to get resolved. So basically, it's a supportive care which is required. And what is the best time to do the X-ray and why? By when we will do X-ray? Immediately, if you do X-ray, will you find all the 5 features in aspiration pneumonitis? Correct. So after 6 hours, the answer is after 6 hours to 8 hours, you should do and see the X-ray, because immediately you will not get the changes in this one. And there is no role of antibiotics in hydrocarbon poisoning. Is there any role of steroids? Can we use steroids for hydrocarbon poisoning? Correct. There is no role for steroids. What is the late effect? What is the late effect of this? So something called lipoid pneumonia happens. Okay, and it is something which will be like oxygen dependent state, some amount of dependence on the ventilation support will be required. So what is the timeline for removal of battery in a button battery injection? So within how much time we should remove the button battery in a case of a child? Means before that time, if you remove, the child will not have that much damage. Somebody told hour. No, actually it is 2 hours. So within 2 hours, if you remove, it will not have much problems. But after 2 hours, definitely you will have to do endoscopy to find out how much damage has happened. And endoscopy should not be done in first 24 hours, because that can also lead to perforation. One more thing I wanted to ask is button battery injection, why it causes severe damage? And where should it be, like for damage to happen, where should it be? Means where it should get stuck. No, so that's a wrong concept. Button-based battery is harmful because it causes alkali release, and that alkali denaturalizes the protein in our body. So because of the alkali, it is very dangerous, and it often leads to esophageal perforation. So button battery goes to stomach, it is not that harmful actually. But if the button battery is stuck in the esophagus, no, and which is the often case, button battery gets stuck in the esophagus and it damages the esophageal mucosa, and sometimes esophageal perforation, mediastinitis, and pneumomediastinum happens, and sometimes a tracheoesophageal fistula can also happen. So these are the most problematic situations with the button battery. And throughout my PG life and even in my ICU training, definitely multiple times I have seen. In my PG time, I had seen a button battery injection case, which was actually ultimately had to go to this one surgery for treatment for the tracheoesophageal fistula. So this is the danger situation with the button battery, and mind you, from my experience, I can tell you button battery injection is very common. In a busy ER, every month 1 or 2 cases will come, because see, most of the toys which children use are having button batteries, and very difficult to diagnose unless you have high index of suspicion. So once what happened is, I was a resident that time. Half of the button battery was seen in the upper portion of the chest X-ray, and from there I figured it out, and then we could do that treatment for the child. So button battery ingestion is a very, very critical thing. And as much delay you make, that much injury to the esophagus happens. So this is the last case because time is running out. Poisoning is a very long topic of discussion, but I just wanted to discuss the basic general principles and some important poisonings. This is a case of a 10-month-old child who is 7.5 kg brought with accidental consumption of 25 ml of 250 mg per 5 ml of paracetamol. So that means how much mg? Basically, the child has consumed 1.25 grams of paracetamol. Okay, but child is still asymptomatic. So what you will do in this case? You will start NAC. Okay, somebody has told start NAC. So first of all, you should know what is the lethal dose of paracetamol poisoning. So 150 mg lethal dose. For not lethal means toxic dose. So, and when should you send the paracetamol or acetaminophen levels in paracetamol poisoning? When should you start sending the levels? This is what I wanted to know. So if you starting NAC can be started. See, one thing is we start NAC empirically in our centers. But what is the ideal time when we should send acetaminophen levels in a case of paracetamol poisoning? Come on, this is a very common question. Actually, it is after 4 hours. Okay. So after 4 hours, you will send. Okay. So see, no treatment for dose which is above less than 150. Gastric levels within 2 hours. Use of activated charcoal is indicated. Toxic dose is above 150. That is 10 times the normal dose. Remember like that. Toxic dose is 10 times the normal dose. Usually we use upper limit of normal dosing of paracetamol is 15 mg per kg. If you are using 10 times the normal dose, that is the toxic level. And you should do at 4 hours, 8 hours, 12 hours, 16 hours levels and plot it. So once you plot, you will get a nomogram, that Rumac-Matthew nomogram. So that nomogram will help you in deciding treatment. But in my practical experience, I would always suggest when a child comes with high dose injection of paracetamol, you can collect the samples after 4 hours, but you can start the NSAID system so as to not have any further damage to the child. Okay, this is the thing. And dosing, there is this is Rumac-Matthew nomogram. You can understand that with the time we are plotting the levels. Okay, and above a certain level, that is a high risk to treat, and there below that level, you should not treat. That is the nomogram indicates when to treat, when not to. And what is the toxic actually element which causes the toxicity is N-acetyl benzoquinone is the toxin. Okay, toxic metabolite which causes the problem. So there are different doses of N-acetylcysteine. It is easily available in manuals. You can just go through manual and administer the particular dose for N-acetylcysteine. N-acetylcysteine is now being used in a lot of ALF cases which are non-paracetamol poisoning ALF cases also. That is a different dose protocol, but this is the standard protocol for NAC in case of paracetamol poisoning. Avoid giving activated charcoal in case if there is plan to give oral NAC, because if you give oral NAC and give activated charcoal, NAC will get binded to the activated charcoal, so it will be not useful. So if you are thinking of giving oral NAC, means oral N-acetylcysteine, then you don't use activated charcoal for that patient. Okay, this is a very important tip to remember. So this ends my presentations, and I'm open to now some questions from you guys. If you have any questions, I'll try to answer to the best of my ability.
I think nobody will be putting in questions because it was such an incredible session, and all the important aspects have been covered. Definitely, toxin and poison is a very, very, very big topic. But most important thing, which like Dr. Sandeep has highlighted, is the general approach. Decontamination in all forms are very important. And I would like to put a comment over here. There is one role of lipid in poisoning. Dr. Sandeep, there's a question by Dr. Shekhar. He's asking what is the role of lipid in poisoning.
Actually, I didn't understand lipid. What is it? But I have not personally used it, so I am actually not able to.
Intralipid.
Intralipid is lipid. I don't think we use it for poisoning. It is used for TPN. I'm not sure whether we use it for poisoning.
I think he wished to ask whether those poison which bound to fat and have a different kind of distribution will be helpful in managing in these cases. So concept of
my knowledge, I don't remember reading this and having practiced this. So sorry for that. I will look up it in the references and try to see if I can find something. But I am not having the knowledge to use intralipid for any poisoning.
Most of the thing which each of a pediatrician should mention to their parents, to the patients, and to the parents as well, is to look out for the preventive aspects in poisons and toxins, because most common admission in hospitals is accidental ingestion, and every month in our unit we admit around 15 to 20 cases. Either it is paracetamol poisoning. Right now there is one child who has ingested 50 tablets of iron sulfate from his grandfather and is presently on desferoxamine. All out poisonings, and nowadays these are some poisons which are readily available in our surroundings. So like we do vaccination visits and we tell them about the nutrition, if we start giving them couple of pointers towards 18 months when they visit us during vaccination, and start telling them that these are the important aspects which they can easily handle and can easily work with their children by keeping the drugs safe in the cabinet, by not allowing or not having medicines in front of their children as candies. So overall, there will be lesser accidental ingestions by the children and thus less morbidity. NAC is a very good medicine, but prevention is the best cure for poisons. With this, if there is no question, we will be ending this session, and I would like to thank Dr. Sandeep for taking out time from his busy schedule and giving us such an incredible overlook and in-depth understanding of how to handle toxins and poisons.
Thank you,
Thank you,
sir.
Dr. Sandeep.
Really delighted to participate and do these academic activities. And I'll be really thankful to you to provide me this platform. Thank you, Nitin, sir.
Thank you, everyone. Take care.